Hi, I'm Vicki Sims. I'm a physical therapist in Gainesville, Georgia. I've been a physical therapist for 36 years. I've specialized in SI joint dysfunction over the last 30 years. It's all the diagnosis I see is one SI patient after another all day, every day. I've been involved with SI surgeries for 30 years as well. The first patient that had surgery that I was involved with was 30 years ago, and she's doing great even to this day. I've been to surgery over 4,000 times. I've seen at least 4,000 patients preoperatively, during surgery, and postoperatively. And of course, hundreds of thousands of conservative patients. But anyway, I'm here to talk to you today to tell you about the surgery, and I wanted to talk about that briefly. What I have found today is that Kim has a sacroiliac joint dysfunction. Of course, this is the sacrum and this is the ilium, and where they fit together is the joint. And I have found that Kim's joint on the right, the ilium has slid up and posteriorly rotated. It's called an upslip with a posterior rotation. And on the left side, it has rolled forward, so it's an anterior rotation. So basically, she's in a torsion. She's right up and back, left too far forward. As it has gone into this torsion, it's pulling the sacrum to the side. Now the sacrum moves on an x-axis, and it's right on left, left on right, this sort of thing. But to keep it simple, I'm just going to say she has a left sacral rotation. So that produces a lot of stretch on the SI ligaments and chronic pain. It starts as a ligamentous problem, but develops into a muscular problem. When the joint's out of alignment, it will send a message to the brain that says, hey, I got a weight-bearing joint out of alignment. So the brain says, okay, you muscles, that whole posture around the pelvis, tighten up. So the piriformis is the most adversely affected muscle, and it becomes very, very tight. The quadratus lumborum becomes tight. The erector spinae becomes tight. The iliopsoas becomes tight. The adductors become tight. The hamstrings become tight or facilitated. And like I said, the most adversely affected is the piriformis, and it will be affected on both sides, typically worse on one side than the other. Kim had a specialized test, a specialized EMG study, which basically shows me that she does have a piriformis syndrome on both sides. It's worse on her right side, I believe it is.
Left side.
Left side, worse on the left.
One-
Got the
1 point.
numbers right here, yes. The left piriformis is much slower than the right piriformis. And it shows that the piriformis is choking on the sciatic nerve as it comes underneath and going to the leg. And that's what's contributing to her quite severe buttock pain, especially when she sits. Because when she sits, the piriformis becomes tighter and chokes on the sciatic nerve more, and she will get buttock pain, burning pain. Patients describe it a lot as a burning pain, and a lot of times a non-dermatomal leg type pain. So Kim does have that. It's on both sides, but very mild on the right side, but quite severe on the left side. So we have decided, the physician and I that's involved in this has decided, because of her SI being out of alignment on both sides, that she's going to need surgery on both. She's going to have a bilateral fixation, and that screws, 2 screws across both SI joints, and a piriformis release. So I'd like to show you the screws that we use are very light. They're titanium screws, and these screws will be just put across the ilium into the sacrum by little puncture wounds. So she'll have 2 puncture wounds, looks a little bit like a snake bite on both sides. She will not have an incision over the SI joint. It's an arthroscopic or endoscopic surgery, and but we call it percutaneous surgery. And it's very, very non-invasive, and she will not suffer much post-op pain. And we're going to put 2 screws on both sides. Now, I play an important part as that I go to surgery with her, and I set the SI joint in complete alignment before the surgical screws are placed across the joint. That way we know that the pelvis is in complete alignment, and it's not going to create problems in the hips or up the spine because of the malalignment syndrome. I'd like to show you a picture of what the bilateral, this is the bilateral surgery. We call it a bilateral fixation. There'll be no fusion in the joint, and the screws never work out. Some physicians have said that the screws will work out over time, but in the 30 years we've been doing this, we have not ever had that problem. They just stay put, there's no motion in the joint, and the pain gradually goes away. Now, in addition to that surgery, we feel like that Kim would benefit from a piriformis release. Now, the piriformis stabilizes the SI joint. That's one of its jobs. The second job is it externally rotates your leg as you step forward. So since we're putting screws across the joint, we don't need the function of the piriformis to stabilize the SI joint. So Dr. Wise is going to make a small incision here on her hip, go down, release the piriformis, and it will retract and get off of the sciatic nerve. That releasing of the sciatic nerve is going to really benefit her to get rid of this buttock pain and the burning pain that she's having. So that's what's going to happen with the piriformis release. She has 3 other muscles that externally rotate the leg, so she'll have no loss of range of motion, no loss of strength. She won't even notice that she's had the loss of this one little muscle. And she will have no limited range of motion in her SI because the SI is not supposed to move very much. So that's what we're doing, is it's not going to be moving. So that's what she's going to do. She will return home in 2 to 3 weeks, and she will do a post-op exercise program, including massage and ultrasound, and hopefully she'll be back on her horse in 3 months. Thank you.